Assalamualaikum warahmatullahi wabarakatuh. Today we are from GOC, and today we will present the case management about the differential diagnosis of unilateral facial swelling. A 55-year-old male reported in the Department of Oral and Maxillofacial Surgery with a chief complaint of swelling on the right side of his face for the past 2 months. He reported a progressive increase in the swelling. There was no history of fever, dysphagia, or difficulty in breathing. Pain and discomfort was present for the last 7 days, with increased swelling and reduced mouth opening. There was no history of trauma. No other skin lesion was present. On, on the examination, the face appeared asymmetrical, with a swelling in the right cheek, which was small, smooth, dome-shaped, present approximately 1.5 cm anterior to the tragus. There is also no evidence of inflammation was eminent around the swelling. Bimanual palpation showed a diffuse, painful lesion in the right muscle region, and the overlying skin was free. The mass was soft to firm in consistency and smooth. There was no associated chill or punctuency. A magnetic resonance MRI was taken, which contrast was done, which showed well-defined enhancing soft tissue nest lesion located anterior to the right mandibular ramus and lower temporalis muscle, with mild surrounding inflammatory and edematous changes.
So this is the differential diagnosis for the case study. It can be dental abscess, cellulitis, salivary gland tumors, localized lymphadenopathy, lipoma, and tumors of muscular origin. Okay, the first differential diagnosis is dental abscess. It can be defined as a localized collection of pus in the alveolar bone at the root and apex of the tooth. So the etiology, it can be due to the bacterial infection, which can be due to dental caries, dental trauma, and poor dental hygiene. The clinical features for the dental abscess is severe pain, localized pain reproducible with palpation, facial erythema, fever, extraoral and intraoral swelling. So the treatment for dental abscess, it can be surgical drainage of abscess and extraction of the infectious tooth. And we should prescribe antibiotics, which is the amoxicillin clavulanate, 875 milligram orally every 12 hours. And the management for the dental abscess, it is proper oral hygiene, eat charismatic food, and less cryogenic food. The next differential diagnosis is cellulitis. So it can be defined as a condition characterized by inflammation and enlargement of one or more of the salivary glands. So the etiology, it can be due to the bacterial infection, which is commonly the Staphylococcus aureus, radiation therapy, patients with Sjogren, Sjogren, patients with sorry, patients with Sjogren syndrome, immunosuppression, and viral infection. So the clinical features, it can be fever, chills, unilateral pain, and swelling in xerostomia. The treatment, it can be a broad spectrum antibiotic therapy. For example, is dicloxacillin, 250 milligram orally 4 times a day, drainage if there's an abscess, hydrogen support, and cialogogues, hydrogen support, and cialogogues. The management is proper oral hygiene, drink water frequently, suck sugar-free hard candy, and chew xylitol.
So our next differential diagnosis is salivary gland tumors. It is the most heterogeneous group of tumors with the greatest diversity of morphologic features. The majority are benign, which is 80%, and 20% of them is malignant. So the epidemiology, 2 to 6.5%, it affect on the neck and head neoplasm. Most common is benign, which is the pleomorphic adenoma. It is 53 to 77% of the all cases occur is in parotid gland. Warthin tumors, 6 to 14% out of all cases, and most common malignancy is the mucoepidermoid carcinoma. The causes of these salivary gland tumors mostly remain obscure. It could be because of infections such as virus infection, EBV, CMV, polyoma virus, and it also can be caused by ionizing radiation. The clinical features, the tumors can increase in size, initially movable, but continue with growth. It becomes more nodular and less movable. It mainly occur at the palatal for the intraoral site. So for the management, one of the management is complete surgical excision and superficial parotidectomy with preservation of the facial nerve. Next. The next differential diagnosis is localized lymphadenopathy. It is defined as enlargement of a single node or multiple contagious nodal regions. The causes are pharyngitis, viral infections such as EBV, toxoplasmosis, and the clinical features. It also increases in size rapidly, pain and tender. If the growth is movable, most likely it is infection due to infection, and if it is fixed, if it is not movable, fixed, it could be cancer. Next. For the treatment and management, medical care is given based on the underlying etiology. So we can give antibiotics. If there is persistent fever or weight loss, biopsy should be pursued sooner. For surgical care, if the lymphadenitis is present, aspirate may be needed for culture, and removal of the affected nodules may be indicated for the management of this lymphadenopathy. That's next.
So for the next differential diagnosis is lipoma. So lipoma is defined by a benign tumor of mature adipose tissue. It is the most common tumor of mesenchymal origin in the head and neck region. So a lipoma is a fatty tumor located just below the skin. It isn't cancer and is usually harmless. Lipoma is a slow-growing fatty lump that is most often situated between the skin and the underlying muscle layer. So the etiology is usually unknown or due to genetic factor. And for the clinical features, the tumor is soft, it has a fluctuant feel, it is generally small, and it has free mobility of overlying skin. It's situated just under the skin. So a characteristic of slippage sign may be elicited by gently sliding the fingers of the edge of the tumor. So the tumor will be felt to slip out from under the finger. So for the treatment, what can be done for this lipoma is surgical removal. So most lipomas are removed surgically by cutting them out. Recurrence after removal are usually uncommon. Possible side effects are scarring and bruising. For the next treatment is liposuction. So this treatment uses a needle and a large syringe to remove the fatty lump. For the management of lipomas, we need to manage the scarring and bruising after lipoma removal and also monitor the progress of the healing. So for the next differential diagnosis is tumors of muscular origin. So there is two tumors of muscular origin, which are Lyomyoma and also leiomyosarcoma. So leiomyoma is also known as fibroids, and it is a benign smooth muscle tumor that is very rarely to become cancer. And leiomyosarcoma is a rare type of cancer that affects smooth muscle tissue. These tumors are most common in the abdomen, but can occur anywhere in the body. So this is the example picture of leiomyoma and also leiomyosarcoma. So the etiology is unknown. It can also be due to genetic, hormone, and also tissue growth factor variation. For the clinical feature, leiomyoma usually present with pain, which is spontaneous or induced by cold or tactile, for example, pressure. It is solitary skin-colored nodules. It is usually well-defined, fairly deep dermal nodules that are smaller than 4 cm. It is often pain to palpation and occur predominantly on the lower extremities, less commonly on the head or trunk, and rarely on the hands or in the mouth. For leiomyosarcoma, the clinical feature, we can see the swollen areas or lumps on the body. It usually present with pain or unusual swelling, and also the patient might have trouble breathing. So for the treatment of leiomyoma, what can be done is surgical excision, and also nifedipine, phenoxybenzamine, and gabapentin may provide relief of pain. So for the surgical excision, it depending upon the location of the tumor. So for leiomyosarcoma, the treatment is also surgical excision depending upon the location of the primary tumor. And also surgical procedure may also include the use of certain reconstructive techniques, and surgical options are dictated by the size, location, and spread of the tumor. And for the management, pharmacologic intervention may alleviate the associated pain.
So next differential diagnosis is cyst. Non-Odentogenesis, because it is in the OPG, it presented no odontogenic maxillary or mandibulary lesion. So the example of the cyst is epidermoid cyst and dermoid cyst. And the etiology of the cyst, it can be infection. And if the patient suffered a cyst, we can see that there is a slow progress of the lesion, and it is asymptomatic. The lesion appear firm, mobile, and inflamed, and men is more prone to have cysts compared to women. And for the treatment, we can do surgical removal of the cyst to remove the cyst. Next is next differential diagnosis is neurogenic tumors. Neurolemoma or schwannoma is a slow-growing benign neoplasm derived from the sheath cells, which is Schwann cells, that compass myelinated nerve fibers. So the etiology of the neurogenic tumors, it is unknown, but it can be associated with von Reichenhausen disease, which is a genetic disorder characterized by the development multiple non-cancerous tumors of nerve and skin. And for the clinical features, males are more common compared to women, frequently in the second and third decade of life, and the tumors are generally well-defined and firm in consistency. A large lesion may present as soft and fluctuant mass, and it is asymptomatic, slowly enlarged, and localized pain. Next, and for the treatment, we can do surgery to remove the tumor. Radiation therapy is also can be done, and it is used to help control the tumor growth and improve your symptoms. stereotactic radiosurgery, in which the doctor deliver radiation precisely to the tumor without making any incision. This you can do if the tumor near vital nerve. So and for management, we can monitor by doing regular checkup and CT scan, MRI to see if the tumor is growing. Further investigation, excisional biopsy was performed, and the histology showed hypercellular stroma with areas having parallel arrangement of intercellular fibers. So we can see at the picture there is intercellular fibers, and tumors in this tumor cell in the stroma were spindle shaped interspersed with fibers forming palisaded arrangement, and numerous areas show myelin-like structures suggest of the bodies. So we can see at the middle of the histology, you can see there is a vertical bodies. Next.
So for definitive diagnosis is Lyomyoma or schwannoma. So for case discussion, so schwannoma is a rare benign neoplasm, which is a neurogenic tumor derived by sheath cell that surround myelinated nerve fibers, which is Schwann cells. So for the clinical features of schwannoma, it presents as slowly enlarging painless mass, usually in the tongue, sometimes with facial pain and/or atrophy of the muscles of mastication. It also is a circumscribed, firm, elastic swelling, usually asymptomatic otherwise. Nerves which are most commonly involved in schwannoma of the head and neck are the vagus and the cervical sympathetic trunk. The site affected depends on the nerve involved, which is the facial nerve or facial palsy. Hypoglossal schwannoma, ipsilateral deviation of the tongue, possibly with associated hematrophy. So in this case, this patient is presented with no facial paresthesia and no motor or sensory functional disability was present. Therefore, the tumor might be arise from trigeminal branch, as trigeminal schwannomas are rarely seen and usually present as large masses due to the delay in the diagnosis and therefore in the surgical treatment.
Okay, discussing upon neurilemoma, the management of this tumor is firstly to locate the tumor. So it requires special investigations such as radiography, CT scan, or MRI as to define the extension of the tumor as well as to locate the specific area, the site of the tumor. So as the origin of the tumor is from Schwann cells, which could also occur on head and neck injury. After that, surgical excision is also indicated as the feature of the tumor is suitable to remove all the diseased tissue, trigeminal schwannoma. However, the recurrency and malignancy transformation in neurilemoma recorded is rare. Okay, moving on to the histology and gross feature of this tumor, there is elongated spindle cells with palisaded nuclei in encapsulated mass with myxoid loose connective tissue. Meanwhile, for the gross feature, it is a unilobular mass enclosed by capsule of epineurium and tumor with residual nerve fibers attachment. Okay, that is all from us. This is the references that we used. Thank you.